Michał, czy wy nas nie słyszycie? Przed chwilą robiliśmy test. O, Michał, we are sharing. Oh, yes. Michał, nie możemy udostępnić ekranu z tego laptopa. Stasiu? Mamy udostępnić prezentację, ale możemy.
No bo wyłączę. Oni muszą nadać uprawnienie.
For the purpose of such thing that happened, I would please ask you to understand that we will let the presenter start over again. Right. Okay.
Okay, so one more time, good afternoon. My name is Natalia Rosso, and the topic of my presentation and review is N-terminal prohormone of a brain natriuretic peptide in gestational hypertension and preeclampsia. N-terminal prohormone of a brain natriuretic peptide is a non-active prohormone secreted by ventricular cardiomyocytes into circulation in response to ventricular overload due to increased blood volume. Therefore, it can be used as a sensitive biomarker for diagnosis and prognosis of a heart failure. The changes in NT-proBNP level during pregnancy have been investigated in multiple studies. Maternal adaptation initiates in the first trimester and continues throughout the pregnancy. Cardiac output increases by about 40 to 50% through the growth in intravascular volume, left ventricular and diastolic diameter, and heart rate. Therefore, NT-proBNP concentrations are much higher in pregnancy than in non-pregnancy. Nevertheless, NT-proBNP level remains relatively constant throughout the pregnancy. It reflects the ability to compensate for the increased hemodynamic load. Conversely, in the case of hypertensive disorders of pregnancy, so HDP, increased vasoconstriction leads to increased blood pressure and afterload. Together with the increased volume of pregnancy, it causes higher NT-proBNP secretion. Presently, HDP constitute one of the most common disorders in pregnant women. They comprise gestational hypertension, so GH, and preeclampsia, pre. According to World Health Organization, in developed countries, 16% of maternal deaths are attributed to HDP. GH is defined as elevated blood pressure, BP, 140 or more, and diastolic BP 90 or more after 20 gestational weeks, persisting for less than 12 weeks postpartum. In turn, pre-E is accompanied by proteinuria and or signs of systemic disease, besides the development of a new onset hypertension. It can be further divided into late onset and early onset preeclampsia, defined as pre-E developed before or after 34th week of gestation. Importantly, pre-E is a life-threatening, multi-system-related pregnancy complication. Despite much research in the field, the pathogenesis of this disorder still remains unclear. As HDP are main reason of maternal and perinatal death, the early diagnosis and prediction of GH and pre are essential for improving maternal and infant prognosis. Anti-proBNP can be used as a sensitive biomarker for diagnosis and prognosis of a heart failure, and is also regarded as one of potential biomarkers of HDP. Therefore, we aim to outline the clinical imperative for the prognostic and diagnostic utility of anti-proBNP in patients with GH and pre-E. Numerous clinical studies investigating the role of anti-proBNP have been already conducted. We searched PubMed's database using the query anti-proBNP and preeclampsia or gestational hypertension or hypertensive disorders of pregnancy. Our search process identified 121 articles, of which 80 were excluded due to the relevant title and abstract. A full text of 41 studies was assessed, leading to the exclusion of another 10 articles due to the following reasons: case control studies, case review studies, and also like reviews. Ultimately, 31 original clinical studies published in years 2001, 2022 were included. 3 of the studies that we included for further investigation were conducted on women with multiple pregnancy, whereas the remaining ones only on women with single-term gestation. In included studies, anti-proBNP levels were measured using different methods, such as in serum by alpha, serum by ELISA, serum by ECLIA, or plasma by REA. The method of measuring of anti-proBNP was not mentioned in one clinical research. Results: a total of 2,124 pregnant women with the pre-E, 406 pregnant patients with GH, and 3,696 normotensive pregnant women were assessed in this review. In the majority of the studies, the anti-proBNP concentrations were notably higher in women suffering from HDP than in normotensive pregnant women. Moreover, the positive correlation between anti-proBNP levels and the blood pressure values in women with GH and pre-E was observed. The negative correlation between gestational age and anti-proBNP in pre-E patients was also demonstrated. Most studies also advocate higher concentration of anti-proBNP in pre-E group compared to the GH group. There are, however, heterogenic results regarding the correlation between pre-E severity and anti-proBNP levels. It was demonstrated in multiple studies that the more severe pre-E was, the higher anti-proBNP concentrations were. However, not all studies found this correlation. Anti-proBNP level appeared to be higher in the early onset pre-E group than in the late onset pre-E group. Anti-proBNP levels were also higher in patients with pre-E compared to the chronic hypertension. However, no such dissimilarities were observed between the chronic hypertension and the GH group. Despite the differences in anti-proBNP levels, there were no significant differences in BP between patients with pre-E, GH, or chronic hypertension. The concentrations of anti-proBNP measured postpartum were also higher in patients with a pre-E and GH compared to the normotensive pregnant women. Nonetheless, the anti-proBNP levels measured after pregnancy compared to the gestation period values increased in controls and decreased in patients with pre-E and GH. Anti-proBNP, therefore, may be considered as a potential biomarker of HDP. Presently, the diagnosis of GH and PE is based primarily on BP values. And increased NT-proBNP concentrations are actually associated with the increased values, such as increased values of the BP. Nonetheless, NT-proBNP values may help in distinguishing between the non-pre-E and pre-E patients, even if there are no significant differences in BP between them. The diagnostic and prognostic utility of NT-proBNP as a potential biomarker of GH and pre-E may include not only binary assessment of these disorders' presence, but also the evaluation of the pre-E severity. Testing NT-proBNP levels, in addition, may be beneficial to the monitoring of a pregnant patient with HGP and women with the history of developing preeclampsia in the previous pregnancies. Thank you very much for your attention. Here are the references. Yeah.
Thank you. I would like to ask all of you to ask your questions.
Okay.
Thank you for your presentation. Very interesting. My question is very simple. What was your personal input into this work? If you could detail a bit. Okay, thank you.
Yeah, so actually, okay, it's working. Yes, so actually I did the whole process of searching and the whole process of maybe from the very beginning. I started from looking for potential biomarkers, generally, because there are actually a lot of potential biomarkers in case of both gestational hypertension and preeclampsia. It's primarily because there's a huge need for those biomarkers. However, NT-proBNP seemed to be the most interesting one, but also it's because it's widely available in clinical panel testing. Therefore, I thought that maybe I should dig a little bit more deeper into that topic. So I did the whole process of firstly searching potential biomarker, then the whole articles, and later on I just also did the work in case of searching a proper the group and just picking proper articles for this review. And later on I just wrote the whole the whole article, actually. Yeah, the whole review.
Thank you, Judge. Thank you, jury, and thank you for your presentation. Now, I would like to ask Rafael Baez to present the presentation on participation in the patient's clinical presentation of chorda tendineae atrioventricular valves pathology.
Good afternoon, ladies and gentlemen. My name is Zuzanna Szewczyk. I'm the second-year medical student at the Medical University of Silesia in Katowice, and I'm going to tell you about the participation in patients' clinical presentation of chorda tendineae atrioventricular valves pathology, which I was working on with Rafał Biaś. The anatomically correct chorda tendineae are attached to a single head of the papillary muscle of the ventricle and a single leaflet of the atrioventricular valve. Chorda tendineae, together with papillary muscles, contribute to the effective contraction of ventricles. Abnormalities of tendon cord structures may result from abnormal cardiac development, trauma, or occur in association with other congenital anomalies and hereditary syndromes. These publications aim to analyze and evaluate the impact of chorda tendineae pathologies of atrioventricular valves on the clinical presentation of the patient. Now moving on to materials and methods, the review of the available literature was performed in PubMed following the PRISMA guidelines. According to the inclusion criteria, we included articles which report participants of all ages and genders. We included case reports and case series. Oppositionally, we excluded systematic reviews. We excluded chorda rupture if they were not due to pre-existing congenital or acquired chorda tendineae pathologies. We excluded articles which report neoplastic lesions and articles with the lack of described etiology. The important aspect to include was that publications which were had to contain a detailed description of chordotendina anomalies of atrioventricular valves and the impact on the clinical presentation of the patient. A total of 592 potentially eligible publications were obtained. After preliminary screening and exclusion of articles which did not fulfill the including criteria, 17 articles were finally listed. The results obtained were divided into 6 categories of abnormalities of tendon cords, such as pathological changes, elongation and thickening of chordotendina, fibrous chordotendina, shortened and absent chordotendina. In each described case, symptoms were not specific, which means that patients had typical symptoms for the cardiovascular system, such as dyspnea on exertion, easy fatigue, edema, or palpitations. The first one is histopathological lesions of chordotendina, which are most often detected spontaneously when the biological material is collected for examination at the time of surgery. And they may result from myoxidal changes of chordotendina fibers, mucinous degeneration, change of fibrinoid without inflammatory cell infiltration as a result of endocarditis, and heterogeneous AA amyloid deposits. In this figure, I show staining results taken for examination at the time of surgery in patients with heterogeneous AA amyloid deposits. Pathological elongation of chordotendina may result from compensation of acquired hair defects, for example, as a result of the enlargement of the volume of heart chambers. It can also result from congenital hair defects such as parachute mitral valve. As you can see on the left is shown parachute mitral valve with reticular tendon strings. Parachute mitral valve is a rare congenital mitral valve defect which may remain asymptomatic throughout life, characterized by unifocal attachment of tendon cords of both mitral valve leaflets to a single papillary muscle. In this case described, there was an irregular interconnection of chordotendina and formation of characteristic mesh. Additionally, on the right is shown an echocardiogram that allowed to detect this anomaly. Pathological thickening of chordotendina may result from congenital hair defects, such as parachute mitral valve, congenital multiple sclerosis, Schwann complex, and acid maltase deficiency, as well as acquired ones, such as infective endocarditis. An example of what thickened chordotendina can look like is this figure, which shows the anterior mitral valve leaflet after removal in patient with bacterial endocarditis. Fibrous chordotendina are tendon strings composed of dense and compact collagen and elastin fibers, which alters their structure, leading to anomalies within them. A review of the literature details a case report of one patient with fibrous chordotendina. The underlying disease that directly contributed to this type of anomaly was endomyocardial fibrosis. In this figure is shown the biological material taken for examination. In figure D, black arrows indicate eosinophils and necrotic myocytes. Pathological shortening of chordotendina may result from drug-resistant right heart failure, blunt white garland syndrome, ventricular septal hypertrophy, and mitral arcade. In this figure are shown surgical findings during the tricuspid valve repair in patient with drug-resistant right heart failure. Arrows indicate chordotendina of the tricuspid valve, and as you can see, they are extremely shortened. And finally, a review of literature details a case report of patients with absent chordotendina, which resulted from the presence of mitral arcade, hypertrophic cardiomyopathy, hypoplasia of the posterior leaflet of the mitral valve, and abnormalities of the subvalvular apparatus of the mitral valve. In this figure, as you can see, arrows indicate direct attachment of the mitral valve leaflet to the papillary muscle. To summarize, chordotendina are important part of the subvalvular apparatus of the atrioventricular valve. They may affect the patient's clinical presentation, but from the other hand, patients with chordotendina pathologies may be asymptomatic for years. Diagnosis was usually based on transthoracic or transesophageal echocardiography, and treatment was mainly consisted of surgical correction. These are references which we use in our review. And thank you for your attention. If you have any questions, I'd be glad to answer all of them. Yeah.
Thank you. Now I would like ask jury to ask their questions.
The second author.
Okay. Oh, fine. Thank you very much. So we have to, as a jury, we have to assess your personal work in this topic. So if you could tell us what was your personal input into this topic, and then what was the reason for choosing the topic for your study?
Okay. First, I would like to focus on the reason. So our friend told us because that she has the addition for the tendina, and we interested about that, started to research this topic and find out that there is no systematic reviews about this problem, and according to our knowledge, this is the first systematic review about this. And my impact is we worked on this. Okay.
So at the beginning, we divide any part of article which we are working on, and we did together research, and then we find out if the research is similar, and then we moved to references to each article to assess any other publication that we did not find. And then when we divide the results to each group, we everyone has 3 groups to describe, and that's how we worked on this.
Okay, so both of you covered this particular topic. Okay, thank you very much.
Thank you so much. Now I would like to invite the next paper, that's Sources, Quantity, Division of Data in Medical Machine Learning Models.
Good afternoon, everyone. Honorable jury, ladies and gentlemen. My name is Michał Azierski. I'm the 4th-year medical student at the Silesia Medical University. And together with my colleague, Marcin Rojek, we've described the sources, quantity, and division of data in medical machine learning models. Yes. The quantity and the diversity of the training data play the important role in machine learning. The collected data are biased by geographical, socioeconomic, and genetic variables, and that might lead to the development of the model that does not meet the criteria of universality. On the other hand, the too little data resulting from, for example, difficulties in gathering of them, or the rarity of analyzed cases, may be completely preventing the training of the model. Data partitioning played a pivotal role in machine learning. We divide the data for the training data, which is used to train the model, the test data, which is used for the initial performance and evaluation, and the validation set, which is used for final results evaluation. There are many approaches to dividing of this data, but the most recommended approach is that the 70% of the data must be the training data, and the remaining 30% is validation and test data. Our goals in this work was to determine the most popular source of training data for artificial intelligence models in medicine, to determine which type of source provides the highest quality of data in terms of quantity, and determine the most popular method of dividing the primary datasets into groups. Using the PubMed database, we primarily search for 344 papers using the keywords prediction, artificial intelligence, or machine learning in range from 2021 to 2022. The criteria for further analysis was that the work must be in English, the consideration of study data sets size and source, and the requirement of at least one of the sets, for example, training, validation, or tests. Finally, we enrolled 100 papers for analysis. During the review, we classified the papers that met the criteria into one of the three groups by noting the method of data partitioning and size of each group. That division is the original study, archival data from a single center such as hospital, and data from inter-center analysis and national programs, as well as their combinations. In this table, we can see the 8 most popular ways of data division. Our hypothesis assumes that groups marked with the one color may actually constitute one set. In that case, dividing 7 to 3 and 8 to 2 would be the most popular method. However, it does not provide the information necessary to distinguish between the validation groups. The red color indicates the participation of the papers in which the full set of data was allocated. That means validation, test, and training. And the red marked column, that's the orthodox approach to the lack of objective feedback about the preferences. What is worth mentioning that only 14% on analyzed papers showcases all three offsets. It might suggest that there are some large gaps in standardization of machine learning approach in medical research. Our analysis shows that archival data is the most commonly chosen source of training data. The second most common source of data is from inter-center studies and public domain. Due to the presence of extreme values, we decided to perform the analysis by comparing the mean number of records for the interquartile range of each group. To conclude, we have shown that datasets originating from a large-scale analysis are characterized by the best quality when it comes to the size, but archival data were only slightly more extensive than original datasets. Here are our references. You can scan this QR code. And that's all from us. Thank you very much.
Thank you. Now I would like to invite the jury to ask their questions.
So I think it's my time to ask you, why do you choose this topic and what's your role in this project?
It's our field of interest, and we chose this exact topic because we think there is a great underestimated lack of standardization in methodology of artificial intelligence model training in medicine, which may result, as my friend said, in a lot of biases implemented in models. We think it is important to standardize this field. And our roles were that we together analyzed the papers and came up with statistical analysis for this, especially the analysis in interquartile range. We have to deal with the fact that there were some papers with extreme values.
So giving your topic, and which is, I believe, very important for the future, your future is the future doctors. I believe that machine learning in general, AI will play a very important role. Just tell me, what are your suggestions for the future? I mean, collecting data, because we all collect data. You as a doctor, we collect data from the patients, we in the basic science and so on and so on. And you see that there is a flow, right, in the way that, do you think the standardization, is it possible to standardize it somehow, that we all, let's say within the European Union, will do it in the same way that will help to obtain the correct results from the AI, right? Thinking, of course, in quote thinking. Okay, thank you.
Yes, we believe that standardization and unification is definitely the answer. However, we must also remember that many approaches in data science are not so easily quantifiable as, for example, writing down some numbers. Some models based on images, videos, or even sound. So it is a great importance of standardization. However, it won't be so simple.
Thank you. Now I would like to invite the next presenter, that is autoantibodies in atrial fibrillation, state of the art.
Okay, honorable jury, ladies and gentlemen, good afternoon. My name is Joanna Zygadła. I'm from Medical University of Warsaw, fourth-year medical student, and today I have the pleasure to present you our review work about current state of knowledge of autoantibodies in the field of atrial fibrillation. Before I get to the principal part of today's presentation, I'd like to start with a brief introduction. Okay, so atrial fibrillation is the most prevalent sustained cardiac arrhythmia in adults. The lifetime risk of AF occurrence was estimated to be about 1 in 3 among population. Currently, the prevalence of AF ranges between 2 and 4%, and a 2.3-fold rise by 2030 is expected. Many independent risk factors of AF have been identified so far, including, for example, diabetes, hypertension, or valve disease. Nevertheless, the pathophysiological mechanisms of AF remain unclear. On this slide, I want to focus on what we know for sure about pathomechanisms of AF. So many studies have highlighted the role of electrical and structural changes in the atria. These changes include ion channels remodeling, atrial fibrosis, and altered autonomic tone. But what about autoimmunity? Autoimmune diseases affect about 7% of the population. Autoantibodies have been found to target various cardiac receptors, modulating the impact of autonomic nervous system on heart rate and conduction system. Okay, in our study, we performed research of literature using the PubMed database and the following keywords: atrial fibrillation, or AF, or arrhythmia, and autoantibodies and antibodies. We included research from inception to September 2022, and after preliminary selection, 85 results were screened for eligibility. Eventually, 31 original research publications, both clinical and preclinical, relevant to the discussed field, were included, excluding only the records that were found by coincidence. So I want to start with the most extensively researched antibodies. These are the antibodies that affect autonomic system receptors, beta-1, beta-2, adrenergic receptor, and M2 acetylcholine receptor. So many retrospective studies have highlighted that anti-beta-1 and M2 antibodies are elevated in patients with AF when compared to healthy controls. Anti-beta-1 were found to be also positively correlated with circulating fibrosis biomarkers, and anti-beta-1 and M2 antibodies were found to be independent predictors of AF recurrence after ablation procedure. There were also two interesting studies on rabbits performed. In one of them, it was proved that immunizing rabbits with beta-2 adrenergic receptors caused them to have atrial arrhythmias. In another rabbit model, immunizing them with anti-beta-1 adrenergic receptors, which caused them to have anti-beta-1 antibodies, caused them to have more atrial fibrosis, TGF-beta, and collagen accumulation that in turn led to AF. Okay, now I want to focus on the heat shock proteins, which are expressed on cell membrane only under stressful conditions. When these proteins are attacked by autoantibodies, it leads to myocyte injury and in turn AF. It was shown that anti-60, 65, and 70 heat shock proteins antibodies were elevated in patients undergoing coronary artery bypass surgery that had post-operative AF. Among other less investigated antibodies, there was plenty of them, such as antiphospholipid, antinuclear antibodies. Only one of them negatively correlated with AF, and it was IgM against the ApoB100 in females. It was statistically significant sex-related difference. Okay, to conclude, most scientific attention has been applied to activating autoantibodies against receptors of the autonomic nervous system. Serum concentrations of various antibodies have been proven to be significantly increased in patients with different types of AF. Worth mentioning is that not only concentrations and correlations have been identified, but also predictive values and possible pathophysiological mechanisms. Nevertheless, the exact role of various antibodies is still a matter of ongoing debate. We propose that inflammatory cytokines and immune cells should be evaluated. And this exact characteristic could provide us with cause and effect relationship that could in turn reveal new perspectives in the treatment and prevention of AF, including the use of immunosuppressive agents or neutralizing antibodies. Moreover, autoantibodies could potentially be used as a pre-ablation screening tool. That would lead to a more individualized therapy with an estimated better risk to benefit ratio. And here is QR code to our publication with full list of references. And thank you for your attention.
Thank you so much. I'll invite the jury to ask the questions.
Okay, the standard questions. Why this topic and what's your role in this study?
Okay, so firstly, why this topic? So, as I mentioned, both immunology and atrial fibrillation are very popular research themes now, and we wanted to connect this, like the most prevalent cardiac arrhythmia and the immunological basis of most of the diseases that affect people. And my input was conceptualization of this, also doing the preliminary research picking up the topics that were relevant to our study and writing.
One more question, please. You caught my attention because in your conclusion, you mentioned cytokines and immune cells that you see as important to study, right? What do you have in mind exactly? Do you have anything like certain?
Because we focused on autoantibodies, which we know are produced by beta cells. Not much research is puts attention to other immune cells, such as other lymphocyte or NK cells. So I think it's more to do in this area. Also, the connection between use of immunosuppressive agents, we are very widely used, and atrial fibrillation is not really researched. So I couldn't tell more about it because there are not much studies. Thank you.
Thank you. Now I would like to ask the online participant, is there a person named Erica? The presentation name is the clinical utility of apolipoprotein A1 and apolipoprotein B biomarkers in cardiovascular diseases risk associated. If the person is there, I'll ask you to please upload your presentation. It is not. Okay, so we'll continue with the next one.
Okay, it's my presentation, this one. This one is mine. I'm present. Excuse me, do you hear me?
Yes, we hear you.
It was my presentation. So, do I have to say it right now, right?
Yes,
it's my fault?
you're
Okay.
audible. Just give me a second. I'll present your presentation.
Okay, sorry. I'm sorry.
One second. Okay, if you're ready, you can share your screen and start your presentation.
All right, just give me a moment.
Okay, sure. Take your time.
Okay, so here. Okay. Or not. Okay. Here and here. Here. Can you see my screen or not? No, not really. So you see my presentation?
Yes.
That's magnificent. Okay, so let's start. Good afternoon. My name is Maciej Baron, and I'm representing the Department of Histology of Medical University of Silesia. I would like to start with a small digression. The diagnosis of the heart disease can be quite challenging. It's often hard to say if the heart disease is inflammatory positive or negative. The solution for this problem is endomyocardial biopsy, which can easily reveal if the inflammation is present or not. And that is the reason why endomyocardial biopsy remains gold standard for myocarditis diagnosis. And now I'd like to prove my words to you by showing you some biopsy pictures. Here you can see the first one, and I have a question for you. Can you see an inflammation? It's right here. It was kind of easy, wasn't it? Okay, let's move on. Here we got another microscopic picture with the same question. Can you see the inflammation? Here you can see 3 examples. However, it was rather hard not to find an information in this picture. But the thing is, the whole procedure of endomyocardial biopsy is quite long because we are starting with myocarditis suspicion. Then we are making the endomyocardial biopsy itself. Then the pathological examination is performed. And next, we are waiting for the results. And depending on the results, we can use a proper therapy. But what if I tell you right now that this whole time can be shortened to only 96 hours? Moreover, it can be shortened in non-invasive diagnostic methods. And now it's a part of the presentation when liquid biopsy came in. Liquid biopsy is a variation of a standard biopsy, in which we are taking the samples from non-solid tissues, for example, from the blood. In liquid biopsy, we are looking for specific biomarkers. Such biomarker might be microRNA. But there is a slightly problem with microRNA. In general, the correlation between circulating and tissue microRNA is not clear and needs further investigation. It's a quote from one of the Nature's reviews. So, the question is, does any systematic review proving such correlation even exist? No. And that was main trigger that performed to make our review. We wanted to find microRNA which might become biomarkers for myocarditis to liquid biopsy. Okay, let's move on to material and methods. 4 databases were searched: Scopus, Embase, Web of Science, and PubMed. The duplicates were removed, and the records were screened by title and abstract. It was later followed by full-text screening. The data was extracted, and the studies were classified according to the subject diseases. Then, the microRNA were assessed using our housemaid scale from 1 to 5, where 5 meant that this molecule has the highest potential to become a biomarker. Each microRNA was finally assessed by 2 researchers, and I have to add that the study was constructed in accordance with PRISMA guidelines. Okay, results. After the removal of the duplicates, we have screened 1,184 studies. However, only 57 of them were actually included to the final review. And here on the slide, you can see all microRNA we have found. Moreover, they are segregated by our scale. But I would like to focus on 3 of them: microRNA 206, microRNA CHR8-96, and microRNA 155, because we believe they have the highest potential of becoming biomarker. Let's start with microRNA CHR8-96. It was extensively validated, however, only in 1 study. It is known by its association with Th17 lymphocytes. However, in the study, it was not compared to the endomyocardial biopsy. Moreover, it was not identified in microRNA sequencing data, and moreover, there are even doubts whether it is or not microRNA. Okay, let's move on to microRNA 155. It was confirmed in 8 studies. It is known by its association with activated T cells, B cells, monocytes, and macrophages. It correlates with a number of CD68+ cells in endomyocardial biopsy. However, there are some voices about its non-specificity, and moreover, it is believed that it rises in myocardial fraction. And last but not least, microRNA 206. It is probably associated with myocardial regeneration. However, the whole mechanism wasn't fully understood. It is not secreted due to myocardial damage. However, it may also be associated with systemic myositis, but it was confirmed in 4 studies. And let's move on to the conclusions. microRNA CHR8-96, microRNA 155, and microRNA 206 are, in I believe, the best candidates to become biomarker for myocarditis to liquid biopsy. However, there is remarkable need of another studies to actually prove their role. But we believe that developing microRNA biomarker technology and artificial intelligence technology may fully replace endomyocardial biopsy in the future. Thank you for your attention, and I hope you did enjoy the topic. And that's all. Well, okay, that's all.
So much for your presentation. I would like the jury to continue and discuss the paper.
Okay, thank you for your presentation very much. Please tell us about your role, what your part in this review. We can see there were there are a couple of you that prepared
yes,
it.
Yes, it was
the conclusion, because honestly, I'm trying to find the conclusion, because from the last slide we were saying that none of those 4 candidates are actually good candidates. So
no. I'm sorry, but I was showing the advantages and disadvantages. I was showing this sites weren't studied correctly in the studies we were searching. That's the first thing. Another thing is my role. I was firstly researcher, Then I was making some of the tables. This one on the presentation with microRNA segregated was done by me, for example. Moreover, to the conclusion, right? You were asking about the conclusions. Our conclusions about depending on the whole studies we have read, is that the best candidates are these 3 microRNA, because the microRNA CHR896, for example, it was only measured in one study. However, it was very good quality study. Moreover, microRNA 155 and 206 were measured in plenty of studies. Moreover, to be honest, both of them rises in myocarditis. So there's huge chance that these two might be biomarkers for the heart disease, for myocarditis especially.
Okay, thank you very much.
Any more question?
Thank you. Thank you for your presentation.
Thank you. Okay.
I'll continue the next one.
Okay.
I would like to ask you to please stop sharing your screen.
Yes. I'm trying. I get a problem.
No issues.
Give me a second, okay?
Okay, so the next presentation is immune-related adverse effects, including the cardiovascular system. Is any of the author on site? Jacob?
Yes, I am. I'm trying to share my screen.
Perfect. Please share your screen and continue.
Give me a moment. Can you see my presentation? Can you see?
Yes.
Okay, so my name is Jakub Pobideł, and I want to present to you a systematic review about immune-related adverse effects, including cardiovascular system, and take a look at the latest scientific report on this topic. At the start, I want to say that immunotherapy was initiated by surgeon William Coley, who observed that sarcoma disappears in patients who had a bacterial infection at the same time. The infection activated the immune system that in some cases was killing the cancer cells, but it was also the time of discovery of X-ray, so everybody forgot about that. 70 years later, scientists observed increased survival of mice with cancer treated with interferon, and nowadays it is known that interferon is inhibitor of the replication of the oncogenic viruses and the modulator of the differentiation and development of immune cells of immune system. Along the way, new hypotheses were created, which kept failing until finally in 2018, scientists discovered the therapy through negative inhibition and regulation of the immune system cells. Can you see another slide? Because
we see first slide all the time.
Okay, I don't know really why, because I'm changing the slides.
Maybe you can just stop sharing and start sharing again one more time.
I think you share only PowerPoint and not whole screen.
Okay. Maybe if I do it like that, you can see another slide?
Yes, now we can see.
Okay. And that was the slide about history, but we are going about what's now. So nowadays, immunotherapy has many varieties, but we are mainly focused on immune checkpoint inhibitors, include, for example, pembrolizumab or nivolumab, because those drugs most often leads to the cardiovascular complication. With no doubt, immunotherapy undeniably has many advantages. The treatment control and damage multiple types of tumors. It can remove residual tumor cells for the body, and the long-term survival rate is scientifically improved. But in our presentation, we would like to focus mainly on the disadvantages, in the particular cardiotoxicity, which in many cases prevents the continuation of the therapy and often leads to the patient's death. So the mechanism of cardiotoxicity is still being investigated, but mainly involves T-cell inflammation mediated by CD4 and CD8+. Immunotherapy also increased the production of pro-inflammatory cytokines and the expression of inflammatory transcription factors. However, it is still not clear what exactly is the purpose of this immune response. In scientific studies, fatal myocarditis was developed in mice genetically predisposed to systemic autoimmunity due to PD-1 deficiency, but in the same mice with the same genetic predisposition but without PD-1 deficiency, the mice did not develop this complication. But recently, scientists have discovered most promising theory explaining what exactly leads to heart complication. Their research also was focused on myocarditis. They discovered that those CD8+ T cells attack a protein in heart called alpha-myosin, but in addition, alpha-myosin not only induces the production of more T cells, but many of the T cells in the heart recognize and capture alpha-myosin. Therefore, alpha-myosin may be an autoantigen. ECI-associated cardiotoxicity is a potentially fatal side effect and requires a high rate of suspicion by treating clinicians. It affects about 1% of all treated patients, but combination immunotherapy is associated with a 5 times higher risk of cardiotoxicity, but also mortality due to ECI-related cardiotoxicity is very high because it's estimated up to 27 to 50%. Diagnosis of immunotherapy-associated cardiotoxicity is difficult because symptoms are non-specific. Patients feel fatigue, chest pain, or shortness of breath, but an elevated serum troponin level is a useful indicator. For example, in myocarditis, which is the most common complication, troponin levels are 40 times higher than normal. Additional tests such as NT-proBNP levels or changes in ECG may be helpful, of course, but there are no specific features indicating the immunological origin. Typically, those complications appear after 2 months of the therapy, and of course, mainly we should focus on looking for life-threatening ones like myocarditis or arrhythmias, but immunotherapy can also develop Takotsubo cardiomyopathy. It is also impossible to say when exactly the immunological treatment should be discontinued for fear of cardiotoxicity. With continued treatment, the risk of sudden cardiac death increases steadily. For this reason, a scale indicated the appropriate management depending on the patient condition was created, and you can see it on the slide on the presentation. At the onset of symptoms of the diseases I mentioned earlier, it is critical to discontinue therapy and start systemic treatment with high doses of corticosteroid immediately. A dose of intravenous methylprednisolone of 1 to 2 milligrams per kilogram per day is probably sufficient in acute condition and may increase the chances of the recovery of left ventricular function by up to 50%. Currently, research is underway on the use of biological drugs in this condition, but at the moment, even if they help temporarily, they will cause even worse heart failure in the future. So, of course, life-threatening cardiovascular symptoms are noticed very late, as pain or weakness is masked by cancer therapy and painkillers. Those conditions are most often detected incidentally during checkups. For patients, most devastating fact is that they are forced to stop immunotherapy, and there are not equally good cancer treatment alternatives for them. New hopes we think that new hope lies in genetic profiling methods that allow the development of an advanced and specific treatment plan for the underlying disease, even for the difficult patient in whom all methods have failed. Any patient, regardless of condition, can be genetically profiled, and these techniques are the most accurate form of cancer screening. What is extremely important, the result allows the detection of specific mutation, which allow the selection of specific therapy for a patient, even in the poor condition. So, of course, the treatment is phenomenally beneficial, but of course, the treatment has also disadvantages. It is super expensive, but optimistically, the price is high, but it continues to fall. So we believe that it will be more common medical practice. So in conclusion, there is a worrying medical issue that there is a noticeable trend towards an increase the incidence of immune-mediated adverse event in the cardiovascular system compared to the previous analysis. Long-term treatment exposes the patient immune system to the drug, which can trigger those autoimmune reactions. And cardiovascular effects are masked by systemic pain and cancer treatment, which is the reason for late detection of pathology. So prophylaxis of oncological patients should be extended and include echocardiography. By recognizing this fact, we can avoid the risk of death and dispense with such an important cancer immunotherapy. And we believe that genetic profiling offers an alternative for patients who have responded negatively to immunotherapy. It allows you to develop a new treatment plan and continue cancer treatment. But unfortunately, this modern and beneficial method for patients is not a common medical practice. And that's all. Thank you for your attention.
Thank you so much. Now I'd like the jury to ask their questions.
Thank you for your presentation. And the usual question, what was your role and what was the reason for choosing the topic?
Okay, so reason was important for me because I heard a story where a patient had to stop immunotherapy for lung cancer because of arrhythmias. It will be my case report in the future. So that's why I decided to think and read more about this part, connecting cardiology and oncology, because I think it is neglected. So I read dozens of scientific articles since 19th century, mainly focusing on the mechanism of this complication, but also on other therapeutic options, because it's for me important that we make better oncologic drugs, but we also have to look on the cardiovascular system of those patients.
Okay, and I have a question because this study is a systematic review, but I don't see any including criteria key to search your studies. Is anything like that in your presentation?
There is very little of those cases because in past immunotherapy was just like the best treatment option. So nobody cares about those cardiovascular side effects. And the new cases are from 2021. So it's a new thing that we are looking for another alternatives for this patient. So there is a very, no, so, okay, that's all.
Thank you so much. Now I'd like to call the next presenter, that is... you can stop sharing your screen. Thank you. It's number 9, macro and microcirculatory endothelial dysfunction in cirrhotic and rheumatoid arthritis, a comparative review. Is the author online? Oh, sorry.
Right. So, okay. Good morning. Good afternoon, everyone. I'm Konrad Kaleta from the Medical College in Krakow, and I want to concurrently invite you to my presentation about endothelial dysfunction in psoriatic arthritis. Okay. So, unfortunately, I don't have a time for a lecture. Okay. One more time. I don't have, unfortunately, time for a lecture about the endothelial role in human physiology. However, I would like to all of you to notice that endothelium is one of the largest organ in our body. If I take my own endothelium and put it in the floor, it will cover a surface of about 4,000 to 7,000 square meters. It is very important because any impairment, any dysfunction of organ that size will strongly affect a human homeostasis. What's more, endothelial dysfunction is considered as a first stage of atherogenesis process, and long duration of endothelial dysfunction could result in higher mortality, cardiovascular mortality rate. Okay, right. Endothelial dysfunction is already well established in almost any diseases. However, especially in autoimmune one. The most of them in rheumatoid arthritis and in SLE. Here are the well established. However, little is known about endothelial dysfunction in psoriatic arthritis, and this is why we consider it in our study. Here is a table made by myself, why this study is all important, clinical significance. I put on this table a calculator for cardiovascular risks, and I show only the calculators here that are highlighted in green that include rheumatoid arthritis as independent cardiovascular risk factor. Okay, so what are the methods that we are used? So we search in specialistic databases, including Medline, Cochrane, MBA Scopus, and the Web of Science. Likewise, the Google Scholar search engine. We used for our purpose to several indicators. So this is methods of measurements of endothelial function. And we use special phrases to this. We put these methods in these three dots. I mentioned the. Okay. What's our inclusion criteria? Our inclusion criteria was loose to include as many studies as it possible. We include original studies, so it is retrospective and prospective observational studies, clinical trials, as well as case reports. However, the case reports, we have only one case report. The paper focuses on a specific method of endothelial analysis, so that they were mentioned in the previous slide, these measurements. We are in our analysis, we are looking for significance. It is not very obvious differences in disease duration. It is an early stage disease or after several years of the disease, type of therapy, other factors provoking endothelial dysfunction, likewise comorbidities such as obesity and diabetes mellitus. In exclusion criteria, I underlined the most present exclusion criteria. So it's insufficient specific information about the PSA patients amid psoriasis population, because these two entities existing by themselves. However, it's very often that we don't have data that we could extract it. So it's one of them. Studies focus strictly on PSA effect on atherogenesis or cardiovascular event were excluded. I only include them into a discussion panel and analysis. The objective is to gather information of any changes 0, 1, if there are any increase or decrease in this parameter, and collection of the precise values that were measured there. So what are the results? Right, so we obtained 1,682 studies, from where 48 were chosen for full text analysis. I write it by these methods. So the first methods, coronary flow reserve, it described the endothelial dysfunction in microcirculation. So it is analogously like in rheumatoid arthritis. Also, the measurements for macrocirculation, such as FMD, CTP, COPB, CPB. I can elaborate this in discussion panel. However, we found that also macrocirculation is also affected in psoriatic arthritis, and these results are very similar to these obtained in rheumatoid arthritis. However, what's really surprising, we found that the parameters that describe arterial stiffness, so it's augmented index, pulse wave velocity, and carotid intima media thickness, were sometimes increased, but these results aren't significant when compared to healthy controls. However, it's really do not, it's not such present like in rheumatoid arthritis. What's really interesting, when we take into consideration an ankle brachial index, the results aren't significant. We cannot make any conclusions from this. So one more time, we found that in psoriatic arthritis patients, there were also microvascular and macrovascular endothelial dysfunction, similarly to rheumatoid arthritis. We have a higher burden of atherosclerotic plaques in large and medium arteries. We found an impaired vasodilatation, increased arterial stiffness. However, it is not significant. It is proposed in studies that we have searched that these mixed results of arterial stiffness is due to a treatment of psoriatic arthritis by anti-TNF drugs. It is very surprising because anti-TNF could even recover endothelial functions. Okay, so our conclusion is that PSA-like array increases the risk of and the frequency of endothelial dysfunction over time. Cardiovascular event prevention for PSA patients are highly needed, and anti-TNF treatment may help improve endothelial function. It should be more research. We have some limitations. There's a lot to be done here, but I am happy to take any questions.
Okay, so it's my standard question. What's your role in this study?
Okay, so I was a head of the study. I make a team. I also planned all the search, search strategy. I planned the inclusion criteria, exclusion criteria. I've also cooperated with my tutor, Mr. Jarosław Nowakowski. So he was on PhD, and his PhD thesis in about endothelial dysfunction in rheumatoid arthritis. But in psoriatic arthritis, there are no study. It's interesting. So he proposed us to try to investigate this problem in the literature, and we plan to develop it further.
Is the size of your team?
Okay, so in my team, we have a 4-person. I can wait.
They were listed.
Yes.
Okay. Here. Yeah. Okay. So their team executed some of the part of the
yes.
data, right?
Yes. I also participate in microcirculatory evaluation. This is why coronary flow reserve.
Okay. Thank you very much.
More questions. You include your first search includes 1,066 studies, and 1,000 of them was from Google Scholar, and no studies from Cochrane and Web of Science database.
Okay.
Why?
So I can explain it. In Google Scholar, when we put a phrase into Google Scholar search engine, it's really hard to take an research because, for example, ABI index have about 20,000 results. Only 980 is available to take them. So in Google Scholar, we make a strategy to take only first 100 results that were have been shown in the site. Yes. In Cochrane it's not a database for taking original studies. There were systematic reviews and meta-analyses there, and the search in Cochrane is like we are looking for meta-analysis and systematic review that are already exist on this topic and take the original studies from them. However, in Cochrane there weren't any studies of any systematic review, any meta-analysis on this topic. We are the first. About Web of Science, it was strange, but we have a problem in our university. So we only started in September. We found no results. We have the same results as in other databases, such as in Google Scholar or something like this. And we have problem to access because our library have a problems. So we cut this out, and I mentioned about it because we started. However, it wasn't ended. Thank you very much.
Thank you so much. The next presentation is online, vaping and its impact on reproductive health, a systematic review. Is the presenter ready?
Tak.
Please present your screen.
Give me a second. Czy widać moją prezentację? Can you see my presentation?
Yes, we can see.
Dobrze. Dzień dobry, Szanowni Państwo. W imieniu swoim oraz opiekuna pracy profesora Piotra Tutki chciałabym zaprezentować pracę na temat wpływu używania elektronicznych papierosów na zdrowie reprodukcyjne oraz płodność. Jest to bardzo istotny temat z punktu widzenia zdrowia publicznego. Już w 2021 roku zidentyfikowano 55 milionów użytkowników. Tak? Sorry?
You can continue, no issues.
Excuse me?
Można kontynuować.
Okej, dobrze. Już w 2021 roku zidentyfikowano 55 milionów użytkowników elektronicznych papierosów. Chwileczkę. Can you see me?
Tak, widzimy.
Okej, dobrze. To już w 2021 roku zostało zidentyfikowane 55 milionów użytkowników elektronicznych papierosów. I warto tutaj wspomnieć, że wśród studentów nawet 14% pali elektroniczne papierosy i już w chwili obecnej liczba użytkowników elektronicznych papierosów przewyższyła liczbę palaczy zwykłych. Jeżeli chodzi o elektroniczne papierosy, to należą one do grupy urządzeń uwalniających nikotynę i zasadniczo różnią się od zwykłych papierosów. Ich głównym składnikiem jest nikotyna, która tutaj w przeciwieństwie do zwykłych papierosów nie jest spalana, a jest podgrzewana i w postaci aerozolu przedostaje się do organizmu człowieka. Oprócz szkodliwej nikotyny, elektroniczne papierosy zawierają również substancje aromatyzujące czy poprawiające smak lub też zapach. I spośród użytkowników elektronicznych papierosów aż 85% stosuje takie substancje zapachowe czy poprawiające smak lub zapach. Wzrost liczby użytkowników elektronicznych papierosów jest alarmujący. Jak tutaj Państwo mogą zauważyć, w 2019 roku było ich 8,5 miliona. W 2020 roku liczba ta wzrosła do 30,5 miliona osób, a co wspominałam już na samym początku, w 2021 roku było to około 51 milionów osób. Jeżeli chodzi o metody, to nasza praca ma charakter systematycznego przeglądu. Przeglądaliśmy 4 bazy danych i analizowaliśmy pracę od 2014 roku do marca 2023 roku, posługując się takimi terminami jak vaping, electronic cigarettes, fertility czy reproductive health, które były zawarte w tytule, w abstrakcie bądź też jako słowa kluczowe i udało nam się znaleźć 72 referencje. Spośród tych 72 referencji wyodrębniliśmy 43 streszczenia, a do ostatecznej analizy zostaną poddane 29 artykułów. Ponad połowa z tych artykułów, czyli 15, znaleźliśmy przeglądów systematycznych, 10 badań przedklinicznych i jedynie 2 badania kliniczne. Tutaj warto też wspomnieć, że metodologia tych badań była różna. Skupiliśmy się na rzeczach, które były najbardziej powtarzalne i najistotniejsze. Elektroniczne papierosy wywierają wpływ zarówno na zdrowie reprodukcyjne kobiet, jak i mężczyzn, tylko warto tutaj też wspomnieć, że liczba prac odnoszących się do kobiet była znacznie ograniczona. Zdecydowana większość dotyczyła mężczyzn. I za tę toksyczność elektronicznych papierosów odpowiada m.in. nikotyna, substancje aromatyzujące czy formaldehyd. Nikotyna wpływa negatywnie na oś podzgórza przysadka gonady, a także nasila stres oksydacyjny w jądrach. Substancje aromatyzujące między innymi hamują ekspresję enzymów, które są zaangażowane w syntezę hormonów płciowych, a dodatkowo na przykład formaldehyd także zmienia budowę jąder. Tutaj na tym przeźroczu w sposób zbiorczy przedstawiliśmy możliwe skutki stosowania elektronicznych papierosów zarówno u kobiet, jak i u mężczyzn, wpływające na każdy organ układu rozrodczego. Osobnym zagadnieniem jest natomiast wpływ elektronicznych papierosów na ciążę. Elektroniczne papierosy mogą opóźniać proces implantacji zarodka, a także hamować sam proces zapładnienia, w związku z czym mogą utrudniać zajście w ciążę, a jeżeli kobieta jest już w ciąży, to mogą mieć one toksyczny wpływ na płód, a także na jego organy, czy też mogą doprowadzić do wcześniactwa. Podsumowując, jest coraz więcej badań, które wiążą wpływ elektronicznych papierosów na płodność, zarówno u kobiet, jak i u mężczyzn. Mimo wszystko większość tych badań pochodzi z badań przedklinicznych, przeprowadzonych na modelach zwierzęcych. Dlatego przyszłe badania, konieczne jest przeprowadzenie większej ilości badań klinicznych, które będą mogły wyciągnąć bardziej wiążące wnioski. Niemniej jednak na chwilę obecną z obecnym stanem wiedzy powinniśmy się skupić na tym, aby ostrzec użytkowników elektronicznych papierosów o potencjalnym negatywnym wpływie na ich zdrowie reprodukcyjne. Dziękuję bardzo.
Dziękujemy bardzo Pani za prezentację. To chcielibyśmy się w takim razie dowiedzieć, jaki był Pani wkład w ten temat. I takie pytanie jeszcze ode mnie. Przedstawiała Pani dane epidemiologiczne dotyczące liczby użytkowników elektronicznych papierosów w różnym wieku. Skąd są te dane? To znaczy chodzi mi o populację. Czy jest to populacja polska, europejska, czy amerykańska, gdzie takie dane się w dużej mierze gromadzi?
Najwięcej i w głównym slajdzie, na tym pierwszym były to dane z USA, z Ameryki, natomiast też tam zawarliśmy informacje odnośnie tego, jak to się ma w Polsce, ale głównie te dane pochodzą z Stanów. A jeżeli chodzi o mój wkład w tę pracę, byłam też pomysłodawcą tego tematu, a także przeprowadziłam przegląd literatury i przygotowałam prezentację.
Okej, a takie pytanie mam jeszcze jedno. Dlaczego Pani w języku polskim przedstawiała, miała Pani prezentację w języku angielskim?
To znaczy, bo było napisane, że każda prezentacja ma być w języku angielskim, natomiast ja się zdecydowałam na przedstawienie w języku polskim, bo po prostu no, jest to język, którym się na co dzień posługuję i wydaje mi się, że no, po prostu czułabym się bardziej komfortowo w tym języku, jeżeli była taka możliwość. Bo to nie jest też sesja, w której ten angielski był tutaj obowiązkowy, więc zdecydowałam się, że chyba wolę po prostu po polsku, żeby się czuć bardziej komfortowo.
Dobrze, dziękuję Pani uprzejmie.
Dziękuję bardzo.
Ja mam jeszcze jedno pytanie. Jak przedstawiała Pani, jakie rodzaje prac zostały uwzględnione w przeglądzie systematycznym, tam były tylko 2 prace oryginalne, ale aż 15 innych przeglądów systematycznych. W związku z tym domyślam się, że musiały istnieć jakieś inne oryginalne prace. Czy one były na przykład wcześniejsze w stosunku do kryteriów wyszukiwania, czy jak Pani wytłumaczy tą rozbieżność?
Tak, jeżeli chodzi o badania, o te prace kliniczne, to w przeglądach było 15 prac przeglądowych, jednak one też zawierały starsze dane. Ja mimo wszystko chciałam się skupić na jak najbardziej aktualnej wiedzy i raczej przeglądać takie badania kliniczne, które są z ostatnich lat, aniżeli takie z 2009 roku, bo takie prace też się zdarzały, jednak wolałam się skoncentrować na tych najnowszych danych.
Dziękuję bardzo.
Dziękuję.
Thank you so much. You can stop sharing your screen now. Now I'd like to invite the next presenter on the topic of innovative methods of treatment of chronic urticaria, a systematic review. Alexandra. Okay.
Dzień dobry.
You can start presenting your screen.
Okay. Prezentacja jest widoczna? Okej, to zakładam, że widać prezentację.
Jest
A więc
widoczna, widać.
Okej. Dzień dobry, Szanowni Państwo. Nazywam się Aleksandra Jęć i mam zaszczyt zaprezentować dzisiaj systematyczne review na temat innowacyjnych metod leczenia pokrzywki przewlekłej, przygotowany razem z Aleksandrą Roztoczyńską. Słowem wstępu, przewlekła pokrzywka jest niepokojącym stanem i może być sygnałem alarmowym wielu chorób w organizmie. Może występować w każdej grupie wiekowej, jednakże częściej występuje ona u kobiet. Charakterystycznym wykwitem w pokrzywce jest bąbel, któremu towarzyszy dotkliwy świąt. Jest on spowodowany obrzękiem skóry właściwej. Może występować w jednej okolicy ciała, bądź być rozsiany na całe ciało. U podłoża powstania pokrzywki leży zwiększona przypuszczalność naczyń krwionośnych, spowodowana degranulacją komórek tucznych, czyli mastocytów i uwolnieniem z nich mediatorów prozapalnych, takich jak leukotrieny, chemokiny czy histamina. Do oceny aktywności przewlekłej pokrzywki służy skala UAS, czyli Urticaria Activity Score, która bierze pod uwagę liczbę bąbli oraz stopień nasilenia świądu u pacjenta. Oba te czynniki mogą być oceniane w skali od 0 do 3. Ta skala może być używana zarówno przez samego pacjenta, jak i przez lekarza. Spektrum kliniczne różnych odmian pokrzywki przewlekłej jest bardzo szerokie. U tego samego pacjenta może współwystępować kilka odmian. Generalnie, żeby powiedzieć, że pokrzywka jest przewlekła, to musi ona trwać przez minimum 6 tygodni. W zależności od tego, czy występuje czynnik indukujący, dzielimy ją na pokrzywkę spontaniczną bądź indukowaną, na przykład właśnie ciepłem, zimnem, uciskiem, może być cholinergiczna. W leczeniu objawowym stosuje się leki przeciwhistaminowe drugiej generacji, np. loratadyna czy cetyryzyna. W przypadku nieskuteczności zaleca się 4-krotne zwiększenie dawki, jednakże zdarza się, że mimo wszystko trzeba zastosować przeciwciało monoklonalne, jakim do tej pory używanym jest omalizumab. Jest on wstrzykiwany podskórnie 1 raz w miesiącu. W ostateczności u pacjenta stosuje się immunosupresję za pomocą cyklosporyny A. Mimo to zdarza się, że pacjenci nie odpowiadają na to leczenie, dlatego potrzebne są nowe, innowacyjne metody terapii, których przegląd jest celem naszej pracy. Przeszukałyśmy 4 bazy danych, takie jak PubMed, Google Scholar, Science Direct i Medscape, systematycznie poszukując badań opublikowanych od października 2018 roku do czerwca 2022 roku w języku angielskim. Wyszukiwanymi terminami były przeciwciała anty-IgE, omalizumab, ligalizumab, UB221, a także spontaniczna przewlekła pokrzywka. W tytule, w streszczeniu czy jako słowa kluczowe zidentyfikowałyśmy 36 referencji z wyłączeniem duplikatów. Z pewnością innowacyjnymi metodami są ligalizumab i UB221, czyli 2 przeciwciała monoklonalne anty-IgE badane pod kątem leczenia pokrzywki przewlekłej. Ligalizumab jest przeciwciałem monoklonalnym, które zdecydowanie przewyższa w swojej skuteczności omalizumab. Z kolei UB221 przewyższa zarówno omalizumab, jak i ligalizumab, ponieważ za pośrednictwem cząsteczki CD23 zmniejsza syntezę immunoglobuliny E. Zagłębiając się dokładnie w te dwa nowe leki, chciałabym powiedzieć, że ligalizumab neutralizuje immunoglobulinę E z około 50-krotnie wyższym powinowactwem, większym odsetkiem odpowiedzi i dłuższym efektem w porównaniu z omalizumabem. Jest potencjalnie skutecznym lekiem u pacjentów z pokrzywką przewlekłą spontaniczną, niereagującą na leczenie omalizumabem, a przed zastosowaniem jeszcze immunosupresyjnej cyklosporyny. Wiadomo też, że ligalizumab bezpiecznie i skutecznie kontroluje przewlekłą pokrzywkę nie tylko spontaniczną, ale także indukowaną, na przykład z zimna, słoneczną, cholinergiczną. Dlatego uważam, że ma zwiększony potencjał, aby być najlepszym lekiem w trudnych przypadkach leczenia przewlekłej pokrzywki. Z kolei UB221, tak jak już wspomniałam, jest mniej przebadanym przeciwciałem, jednakże tutaj przepraszam za jakość, ale znalazłam tylko taką ilustrację, a zależy mi, żeby pokazać, że on nie tylko wiąże wolną immunoglobulinę E w surowicy krwi, ale także za pośrednictwem cząsteczki CD23 zmniejsza jej syntezę, czym przewyższa wspomniany już ligalizumab i omalizumab. Do tej pory pojedyncza dawka podana pacjentom w pierwszym badaniu klinicznym wykazywała trwałą poprawę objawów choroby. Podsumowując, pokrzywka przewlekła stanowi często bardzo trudny problem kliniczny z uwagi na długotrwały charakter objawów i złą reakcję na leczenie, często związaną z tym obniżoną jakość życia pacjenta. Dlatego uważam, że potrzebne są nowe, innowacyjne metody jako opcje terapeutyczne oraz kolejne badania nad lekami takimi jak ligalizumab i UB221. Dziękuję bardzo.
Jeżeli chodzi o pytanie, to jak zawsze pytanie, jaki był Pani wkład w tą pracę, a dodatkowo, czy któryś z tych dwóch leków, o których Pani mówiła, jest już dostępny w Polsce?
W zasadzie to temat prezentacji był moim pomysłem, ponieważ znam osobę, która właśnie boryka się z takim problemem i ciężko odpowiada na leczenie, dlatego postanowiłam zagłębić się w ten temat. Z tych publikacji, które przeanalizowałam, wynika, że nie. Trwają właśnie teraz, w zasadzie ma być wprowadzany ten ligalizumab, ponieważ UB221 jest jeszcze zbyt mało przebadany, żeby móc go zastosować na szerszej grupie. On został podany w pierwszym badaniu już klinicznym, ale na razie w czasie ciągłej analizy też jego bezpieczeństwa farmakokinetyki i farmakodynamiki.
Thank you so much. That's it. You can stop sharing your screen now. Now I would like to invite the next presenter, that's new cardio prevention strategies in cardio-oncology based on the ESC guidelines 2022.
Dear jury, dear participants, my name is Karolina Pasierb, and I will give a presentation about new cardio prevention strategies in cardio-oncology based on the European Society of Cardiology Guidelines 2022. Specifically, I'll be focusing on the TBIP acronym and TBIP acronym, which was firstly introduced in mentioned guidelines, and anticoagulation therapy in atrial fibrillation and venous thromboembolism in cancer with patients with cancer. I cannot really. Thank you. TBIP is a structural approach to anticoagulation for venous thromboembolism and atrial fibrillation in patients with cancer. It gathers important risk factors which have to be evaluated before administering those kind of therapy. TBIP stands for thrombotic risk. And here for risk stratification, CHA2DS2-VASc score is suggested. For assessing bleeding risk, a Hasbled score is recommended. Then we have to evaluate drug-drug interactions and then patient's preferences. We have to discuss every possible side effects, the route of administration, what's possible, what's not for our patients. It's crucial for patients' compliance. Atrial fibrillation, this may be a marker for specific type of cancer, or it can even mask a cancer. It's also a great risk factor for developing systemic thromboembolism or a stroke. As already mentioned, CHA2DS2-VASc score is dedicated for thrombotic risk assessment. When the score is 2 or more in men or 3 or more in women, then long-term anticoagulation should be considered. In patients without any bleeding risk, first drug choice are novel oral anticoagulation. However, many trials and meta-analyses have shown that this drug group has many drug-drug interactions, also with cancer treatment, and it increased bleeding risk. That's why in patients with an operative or residual gastrointestinal or genitourinary cancer, thrombocytopenia, renal dysfunction with creatinine clearance less than 15 milliliter per minute, low molecule weight heparin should be given. Then, if we have a patient with moderate to severe mitral stenosis or mechanical prostatic valve, vitamin K antagonist should be given. Unfortunately, this drug group has really narrow therapeutic window and need close surveillance. When our patient is at high risk of bleeding, a good alternative to pharmacological anticoagulation, left atrial appendage occlusion device is great to propose. Also, reassessment during follow-up, reassessment of bleeding risk or thrombotic risk should be done every 3 months, just to make sure we are administering the right treatment. Venous thromboembolism, it may be a very first clinical sign of malignancy, and here incidental or symptomatic venous thromboembolism share the same therapeutic algorithm. Cancer patient without any bleeding factors, exactly as previously in atrial fibrillation, should receive novel oral anticoagulation for minimum 6 months. When our patients have increased bleeding risk, then low molecule weight heparin should be given for beyond 6 months up to 12 months. Also, prolongation of anticoagulation therapy in active malignancy, including metastatic disease, should be given. And also here, periodic bleeding and thrombotic risk reassessment is crucial. When venous thromboembolism is associated with a catheter, our our treatment depends on whether the catheter was removed or not. When it was removed, anticoagulation should last minimum 3 months until we confirm resolution of the thrombus. When it remains in situ, long-term therapeutic anticoagulation is recommended. Venous thromboembolism relapse under anticoagulation. In this case, we should thoroughly investigate if our patient has good treatment compliance, good treatment adherence. We also have to think about cancer progression and cancer relapse. Also bleeding and thrombotic risk should be, of course, reassessed. And maybe it's a good option for our patient replacing novel oral anticoagulant with low molecule heparin. Thank you for your attention.
Thank you so much. I'd like the jury to take the questions.
I have my standard questions. What's your role in this study?
I specifically assessed diagnosis and management and end of cancer treatment in these guidelines. Unfortunately, this 7 minutes presentation is too short for talking about all the things we have found as new cardio prevention strategies. That's why I decided to talk about TBIP and anticoagulation therapy. So I based my presentation on guidelines, and then I assessed using PubMed searching tool new articles, which was published in 2022 and 2023 regarding this topic. Thank you.
Thank you so much. Now we'd like to call the next presenter, that is Coach COVID-19 Influence on Athletic Cardiopulmonary Health, a Systematic Review and Meta-Analysis.
Okay, so good afternoon. Can you hear me? Can you see me?
Yes, please share your screen.
Yes, of course. Wait a second. Okay. So can you see my slides?
Yes, we can see.
Okay, and they are trending, I see. Okay, thank you very much. Okay, so once again, good afternoon, ladies and gentlemen, dear scientific jury. My name is Grzegorz Procyk. I am a fourth-year medical student at the Medical University of Warsaw, and I have the great honor of presenting to you the results of our systematic review and meta-analysis of COVID-19 influence on athletic cardiopulmonary health. So first, let me introduce you to the plan for today's presentation. I will start with some background, then objectives, followed by materials and methods used in the review. After that, I will present the results and try to draw some conclusions. At the very end, I will be open to any questions, so please write them all down. Okay, I believe that I don't have to tell you how significant an impact COVID-19 has had on our lives. Up to now, almost 700 million cases have been confirmed, and nearly 7 million people died because of COVID-19 worldwide. COVID-19 infection also significantly influenced professional athletes, potentially decreasing their exercise performance. We asked ourselves, how could we measure this potential effect? And VO2 max was our answer. VO2 max, also known as maximal oxygen consumption, maximal oxygen uptake, and maximal aerobic capacity, is by definition the maximum rate of oxygen consumption attainable during physical exertion. The average untrained healthy male has a VO2 max of approximately 35 to 40 milliliters per kilogram per minute, while elite athletes, such as competitive distance runners or racing cyclists, can achieve VO2 max values exceeding 90 milliliters per kilogram per minute. So the aim of our study was quite simple. We wanted to assess the impact of COVID-19 infection on athletes' endurance capacity, considered as the VO2 max. We hypothesized that COVID-19 infection decreases VO2 max in those athletes. In our systematic review and meta-analysis, we included observational studies because these were the only ones that we found in the databases. And these observational studies assessed post-COVID-19 change in VO2 max in athletes compared to either pre-COVID-19 VO2 max in the same athletes or VO2 max in non-COVID-19 healthy reference athletes. Very notably, we included only studies where VO2 max was defined as the average value in the 10 to 30 seconds interval before the cardiopulmonary exercise test termination. It's an essential annotation because there is some inconsistency in the literature regarding the nomenclature. I mean, precisely VO2 max versus peak VO2. So here is the flowchart of our research. We searched 5 databases. This is Embase, Medline Ultimate, PubMed, Scopus, and Web of Science. We found 526 records, and after the removal of 232 duplicates, we screened almost 300 records. We excluded 277 records during the screening, and then 14 records were assessed for eligibility. We eventually included 7 studies, excluding reports with insufficient data, case reports, and research on the pediatric population. So now, the most important part of our study, so the results. VO2 max measured before COVID-19 didn't differ from VO2 max measured in the same athletes after recovery from COVID-19. Secondly, VO2 max measured in reference healthy athletes not suffering from COVID-19 didn't differ from VO2 max measured in athletes who recovered from COVID-19. The pooled analysis of these 2 subgroups also found no difference in VO2 max between non-COVID-19 and COVID-19 athletes. So let's move on to conclusions. But before I draw any conclusions, I must mention some limitations of this study. So first, heterogeneity between included studies. Although all these studies assess the same variable, this is VO2 max, some critical differences in study design might influence the analysis. Secondly, a relatively small number of included patients, and that results from the fact that there were also relatively small groups of athletes in included papers, and also there were not so many papers on this topic. Okay, and next limitation is, of course, publication bias. It is a significant problem while conducting a meta-analysis, but hopefully the change in journals policy will help to overcome this problem in the future. And last but not least, data format. There is something particular on my mind. One study presented the results grouping patients differently than other studies, and then I had to make some mathematical transformations, but of course statistically justified. Okay, so knowing all the limitations, I will present you with 3 main conclusions. First and most important, COVID-19 doesn't significantly influence VO2 max in athletes. This finding advocates returning to regular training by athletes after undergoing COVID-19, but nevertheless, a complete health examination may be required to ensure a safe return to play for selected individuals. And that's all from me. Thank you very much for your attention, and I would be glad to answer any of your questions.
Thank you so much. The jury will take over for the questions.
Thank you very much for important topic, of course, and very nice presentation. Tell us about your role in the study, and the question that drew my attention was you were testing the athletes, which I believe because of the way of life, they were somehow protected, right, from the COVID effect on the pulmonary system. But what is your opinion about the healthy individuals who went through the COVID infection? Do you think they would be as unaffected as the athlete?
Okay, so thank you very much for these questions. I will start answering the second one maybe, and then I will tell about something about my input to this work. So as you said, I also think that in not elite athletes or even either in not athletes, there will be something different observation from in here is found in here. Because as you said, athletes are some kind protected because they train over 3-4 times a week. And it is a great topic for another systematic review and meta-analysis. But I think that there will be a much more reports on this topic. So it would be also much harder to get through all of them. But I think that if we do so, then it would be also a great meta-analysis. But answering, yes, I think that observations and results would be different. But I don't know because I haven't conducted this meta-analysis that you mentioned, and we decided to conduct our meta-analysis on athletes because especially my friend is interested in the sports medicine, which is also a very emerging part of medicine right now, and that's why we decided to analyze this particular topic. Especially that one of the included studies, one of these 7 included studies was the research made by my friend and their team. So that's the second question. And the first question, so what was my input to this work? Maybe I will start also answering the other way. So a friend of mine, the other author, proposed the idea for this meta-analysis and systematic review. And then I have conducted the whole systematic review, so literature review, and the whole statistical analysis, the whole meta-analysis. Of course, I could always rely on his advice because, as I said, he is more interested in this particular topic, while I was responsible far more for the statistics and the literature search, so conducting the study basically.
Thank you so much. You can stop presenting your screen now.
Thank you very much.
Now I'd like to call the next presenter, surgical treatment outcomes of children with congenital heart diseases in sub-Saharan Africa.
Good afternoon, my fellow people. My name is Rabiu Adamu. I'm presenting the research of surgical treatment outcome of children with congenital heart diseases in sub-Saharan Africa under the session of systematic review and meta-analysis 2. With my work tutor, Febo Tufe Ade Busoi. The background of the study is congenital heart diseases, which refers to the range of structural defects in the heart that are present at birth and affect millions of children in sub-Saharan Africa. Surgical therapy is the most common treatment modality in SSA due to its cost effectiveness and availability of basic surgical equipment in hospitals. The study aimed to analyze the surgical treatment outcome of children with CHD in SSA. Material and method. A review of literature was conducted to identify studies that report on the surgical treatment outcome of children with CHD in Africa. The search was performed in PubMed, EMBAS, and Scopus database, using the keyword congenital heart disease, surgery, and sub-Saharan Africa. Studies were included if they reported surgical outcome, such as mortality rate, survival rate, or complications. The results. The primary analysis of this research involved 18 studies, but only 7 of them were deemed suitable for the final analysis. These 7 studies examined 850 patients who received surgical treatment for CHD in sub-Saharan Africa. The findings indicate that the average rate of complication was 28.2%, while the average mortality rate was 8.5%. Nevertheless, the average survival rate was 41.1%. The second result shows 6 countries, Nigeria, Congo, Ethiopia, Tanzania, Uganda, and Kenya, accounted for 53.5% of the bed prevalence. In Ghana, 20 patients with tetralogy of Fallot, pulmonary atresia, underwent palliation, and 50 of the tetralogy of Fallot, 36 double outlet right ventricle, 14 underwent repair. Hospital mortality was 0% for palliation and 4% for repair. Only 6 of the expected 1,234 cases of conotrachal defect underwent palliation or repair within 2 years. Then the conclusion: surgery is a valuable and cost-effective method to treat CHD in SSA. However, it comes with a substantial risk of complication mortality. Therefore, enhancing the quality of surgical care for CHD patients in the region throughout the implementation of advanced pre-surgical screening, surgical techniques, and post-surgical care is recommended. The keywords is congenital heart disease, sub-Saharan Africa, and cardiac surgery. Thank you.
Thank you so much. Jury, please ask your questions.
Thank you very much for your presentation. What was your role in this systematic review?
The role is I did the presentation, I did the research, and my team helped me to cross-check it and finalize the results.
Okay, thank you.
Thank you so much. Now the next presentation is diabetes mellitus type 2, why exercise works when insulin fails, a systematic review. Is the presenter there online?
Yeah, good afternoon. Can you hear me?
Okay, perfect. Please share your screen.
Okay, just a minute. Please, can you see my screen? I just want to confirm that.
Yes.
All right, thank you. Okay, once again, good afternoon, everyone. My name is Ibiojo David. I'm a student of Kiev Medical University. So today I'll be speaking or presenting on the topic diabetes mellitus, why exercise works when type 2 diabetes mellitus specifically, why exercise works when insulin fails. So I'll just want to do a quick background. And firstly, I would like to say diabetes mellitus is becoming a more serious disease within the healthcare sector, and it's coming about with a lot of increased disease burden. And it's part of its characteristic, as we know, will be presence of hyperglycemia and insulin resistance in type 2 diabetes mellitus. Now, this is actually like a chronic illness with severe and more serious long-term consequences. You have cardiovascular diseases, neuropathy, retinopathy. And just to say that diabetes mellitus is one of the leading cause of blindness in our world today, as well as one of the leading cause of amputation. And sorry, now despite the fact that insulin therapy and a variety of other medications are frequently used to lower blood sugar levels, some individuals may not respond so well to this course of treatment, necessitating the use of additional therapies to enhance glycemic control. The metabolism of glucose has been proven to be enhanced with exercise. Now, this picture is it's an attempt to show how far civilization has brought us, and to more of stress the fact that I would say in this civilization we are becoming. People would argue that, oh, probably we eat more, that's why there is a high prevalence of diabetes mellitus amongst this civilization. But then with this picture, what I'm trying to illustrate is I would want to probably argue that this is a consequence of more inactivity in this civilization, as many studies would actually go on to prove. So the aim of the study, like I've almost covered, is to seek to understand why, in the absence of efficient insulin therapy, exercise can be helpful in the management of particularly type 2 diabetes mellitus. Now, to achieve this goal, the available evidence of the physiological, molecular, and cellular pathways that facilitate the effects of exercise on glucose regulation and the presence of insulin resistance will be examined. Now, for materials and methods, most of the papers, if I would say that we reviewed, were actually from PubMed, Google Scholar, Cochrane Library, considering between 2009 and 2023, using various keywords like exercise, glucose transporter type 4, and type 2 diabetes. Now, in the course of the would I say research, quite a lot of interesting things were discovered. The majority of research showed that glycemic control and insulin sensitivity and glucose uptake all significantly increased or improved as a result of exercise interventions such as aerobic exercise, resistance, or a combination training. Exercise has also been linked to lower levels of HbA1c, fasting glucose, and insulin resistance. Additionally, certain studies indicated that this effect could be achieved through a pathway that is not related to the insulin pathway. Now, physiologically speaking, what we'll know, or should I say the conventional physiology will know, is insulin facilitates the movement of glucose from the bloodstream into tissues, right? And particularly the glucose transporter responsible for this effects perpetuated by insulin is actually the GLUT4. Now, in the case of the type 2 diabetic patient or person, if I would say, there is actually a problem with either the signaling pathway. If a lot of things can go wrong when you actually check the signaling cascade of things causing about glucose uptake into tissues using GLUT4 transporter, you see it's a very, very complex pathway, making it prone to things going wrong. Now, having said that, in most of the studies we did, we found out that exercise also facilitates glucose uptake into tissue. In this sense, now particularly the muscle, right? And in the course of the study, it was geared toward why was exercise responsible for that uptake, and is it more of how do I say it? Is it using a different pathway, so to speak, or it is using the same pathway as the insulin? So in the course of the review of certain papers, we discovered that the pathway for insulin regulation of blood glucose is actually very different from the pathway of the exercise. And this is why we said that in people with type 2 diabetes, which most of the time they would have issues with their insulin pathway, exercise is an alternative way to help them get their glucose under control. Now, like I've explained, this is a representation of when insulin pathway is knocked off. Like this whole cascade is showing, okay, the the conventional or the normal pathway insulin we take to interact with its receptor, activation of IRS1 protein, leading to translocation of the GLUT4 protein. And now the interesting facts, or which is, would I say, the center of my presentation today, is about, majorly everything is about this slide. So exercise and insulin regulates glucose transport via distinct signaling mechanism. Now, if you look at the top left corner, I knocked out the insulin pathway. Then you look at this top, maybe the right part of this picture here, you see that exercise is still functional. And now the question is, why would exercise work when insulin is failing? It is because of the molecule referred to as AMPK. Now, AMPK is would I say, the major target or the major molecule that is being targeted through the exercise pathway. Now, this pathway is able to still cause the translocation of the GLUT4 receptor to the membrane surface for glucose uptake. And like I've said, a lot of other things can actually activate AMPK, like we found out in the course of reviewing papers. And actually, AMPK is a very, very, very highly researched molecule because of how almost ubiquitous it is in the body. So to conclude, exercise and insulin increase glucose transport in skeletal muscle, resulting in glucose clearance from the blood, which is the goal for every diabetic patient. Exercise and insulin increase glucose transport through the translocation of GLUT4 transporters to the cell surface and transverse tubules in the skeletal muscle. Now, there are distinct proximal signaling mechanism, which is the point of emphasis for exercise and insulin-stimulated GLUT4 translocation. And now ACAR, which is an AMP
Your time is up.
mimetic.
Please skip to conclusion.
Yeah, thank you. Increases AMPK activity and can increase glucose transport in skeletal muscle. So this is a pictorial representation of benefits of physical exercise, if I would say, and then, yeah, so thank you.
Thank you so much. The jury will take over.
Thank you very much for
Okay.
your presentation. Two questions from me. First, of course, what was your role in that research? And second,
Yeah.
one more like a comment and a question in one, because looking at your first graphical figure, right, that you showed the evolution of human towards American population, we would say that we are already in
Yeah.
diabetes mellitus Armageddon, right? But of course, we know that
Yes,
it's different in
exactly.
each country and region. We do not all eat McDonald's
Yeah.
every day, all day long, whole life.
That's true.
But what do
Yeah.
you think? Each country is hustling right now with the diabetes mellitus problems and generally metabolic diseases. Is the exercises only as a therapy possible to stop the development of the disease, and up to what moment?
So for the first question, my role in the work for this presentation was to basically the topic and as well get materials by using the search engines I mentioned in the materials and methods, relevant materials, while looking at the criteria we stated in the materials and method. That's one. And to answer the second part of your question, like the picture depicted, it's more of an American society. And like you rightly pointed out, it's almost like we're in the era of diabetes Armageddon. So I would like to argue that exercise can be used as an adjunct therapy in addition to whatever treatment. That's one. And also, I would like to say the prevalence of diabetes amongst this civilization, I would really like to argue that it's can be and it's almost tied to increased inactivity amongst this civilization. It's almost irrespective of the diet or what we consume as per location dependent consumption of food and nutrition and all of that.
Very much.
Thank you.
Sorry, I'll repeat again. Evaluation of the effectiveness and safety of colchicine in prevention of atrial fibrillation.
Thank you. Thank you. Hi, my name is Maram Abubakar, and I'm here to talk about the evaluation of the effectiveness and safety of colchicine in prevention of atrial fibrillation. So, sorry, is it okay? Okay. Okay. So the first thing I'm going to talk about is the background of atrial fibrillation, and then it's mostly known as AFib or AF. And it's an irregular or rapid heart rhythm that is due to like asymmetrical rhythms between the atria and the ventricles. While as well, it's due to the lack of signals from the signal nodes. And then this SA nodes, if they have lack of signals there, it can literally lead to the atrial fibrillating or twitching in a very fast or chaotic way. And then there's also a marker to indicate atrial fibrillation inflammation. And this deals with the fact that there's an increasing CD45 plus and CD68 plus cells, macrophages leading to it. So for colchicine, I'm going to talk a little about it. So colchicine is an alkaloid extracted from the plants of genus Colchicum, and it disrupts microtubule assembly of leukocytes by binding the beta-tubulin and forming tubulin colchicine complexes. While microtubules are important in certain cellular cytoskeletal functions, and then this might also help by inhibiting various leukocyte functions. So colchicine normally has an anti-inflammatory effect, and this anti-inflammatory effect can be used to treat certain inflammatory conditions like gout, Behçet's disease, and then familial Mediterranean fever, which is known as FMF. And then most recently, which I'm going to talk about in this presentation, is the fact that it plays a role in maybe reducing the post-operative atrial fibrillation incidence. So for this, I will talk about the mechanism of colchicine. So for the first part, which is A, the dotted lines represent the ones that are inhibition, and then the straight lines represent the ones that are stimulatory. So for the first part, which is A, colchicine helps to inhibit innate immunity, phagocytosis, caspase-1 activation, and then it also inhibits chemotaxis factors from being gotten from neutrophils. And then for the B part, we can have that colchicine at high concentrations, it leads to L-selectin shedding, while at low concentrations, it reduces and inhibits E-selectin, which helps in neutrophils adhesion. While for C, colchicine plays a role in inhibiting the presence of interleukin-1, interleukin-8, and then superoxide. While for D, the antigen presentation, it helps to stimulate dendritic cells to become antigen-presenting cells, and also having the tumor necrotic factor, which is TNF. And for E, colchicine helps to inhibit the vascular endothelial growth factor, which is VEGF. So for the methodology of studies, we decided to conduct a systematic review using 15 articles. We landed at 15 articles, if you can see here. We decided to use Prisma to make our Prisma flowchart here. So for the first one, we're going to talk about the records identified from the databases. We used PubMed, we used Cochrane, which we also use RevMan for it. And we use Google Scholar, we used PubMed Plus, NCBI, and then the National Institute of Health. So we divided them by excluding the ones that do not contain information about cardiovascular diseases, non-cardiac surgery, and then insufficient data, leading to 15. And then 3 of the studies that we got from these 15, they served as our main focus. So for the results, we have 3 positive outcomes out of the 5 studies that we did. So the first one was a randomized placebo-controlled study. And if you can see in these 2 slides, we used JAMOVI to make a meta-analysis. This is the heterogeneity statistics, the tau square, the I-square, and the heterogeneity, which we present as 0. And then the right can represent the 5 studies that we had, the Imazio, Tabalat, Zarpelon, Tabalat et al., and then the Schwartz et al., which is our randomized effects model. The black dots represent the odd risks, right? The black line straight up represents the confidence interval, which is known as 95%. And then the second one, colchicine group had a lower incidence of POAF, 12.0% versus 22%, and having a p-value, which is gotten into the Q-test as 0.021, and a relative risk reduction, 45% compared to placebo. So this is our funnel plot gotten from our meta-analysis. And 2 of the 5 studies they reviewed, and they showed that diarrhea was a severe and complication, which is about 24.6% in patients that were found. And the primary endpoints of this atrial fibrillation occurred in 14.5% of the colchicine group and 20.5% in the non-colchicine group. So the relative risk in this case was 29.3% and the p-value of having 0.14. And then if you can see in the funnel plot, we plotted the graph against the standard error and the log odds ratio. So the mid representing, the left representing less outcome of the negative effects, and the right representing more outcome of the negative effects. So basically, for our conclusion, we can say that colchicine may play an actual role in reducing the prevalence of post-operative atrial fibrillation, POF, and also cause side effects such as GIT problems, motility, and diarrhea. So these side effects, they're recorded together with the positive outcomes. And up to 10% of these patients, they might not be able to use it because of the GIT effects. The most important thing about using colchicine is the fact that you have to use moderate to low doses, which are about 0.5 milligram to 1 milligram without a loading dose. And then also, they tend to interact with certain medications like statins and cause visceral toxicity, which can occur in the liver or the kidneys as well. And then another important point to note is to maintain and check certain blood components or component markers like the transaminase and also the creatine kinase. These are our references gotten from Curious, Journal, IMRA, Jamovi projects, the one for the meta-analysis, the Prisma. Thank you.
So I have two questions. One is our standard question, what was your role in this study? And the second question is you identified 15 studies and in meta-analysis you include only five.
15 articles.
15 articles?
Yeah.
So why there are only 5 in meta-analysis? Could you tell one more time? Because
Okay, so I'll answer the first question, Maro. Maro was basically doing the systematic review and the meta-analysis, basically going to Prisma to create a Prisma flowchart, and then using the endnotes to be able to identify the ones that were repeated articles as well. While the second was the meta-analysis, I used 4 meta-analysis packages. The first one was the Revman 5.0, which is gotten from Cochrane Library. And then the second one, I had to learn how to use the R language to do in the R studio to get the metaphor package. And then the third one is the JASP, and the fourth one is Jamovi. We basically conducted the meta-analysis with these 4 packages to be able to know whether they will be in alignment with the results and the conclusions. So the last one that we decided to use was the Jamovi. I created the dichromatous study models, the funnel plots, the random effects model, and the heterogeneity statistics. So for the second question, we basically using the Prisma and everything, we got 15 articles and 5 studies because most of them are repeated. And each article that we reviewed decided to use the same studies on and on because it is still a work in progress.
Thank you so much. The next presentation is cardiac representation of dysautonomic disorders in Guillain-Barré syndrome, a literature review. Julia Mas, is the presentation online? Is the presenter online? Sorry. Okay. Stationary. Thank you very much. Okay, it works. Yeah. Yeah. Let's upload. Dobra, to zacznę od tego. Firstly, a few words in English because I decided to speak in Polish, but that's why much more notes on our slides to help our foreign colleagues understand my speech. Więc dzisiaj już przejdę do sedna do sedna mojej prezentacji. Zajmiemy się tutaj kardiologicznym tłem choroby, jaką jest Guillain-Barré syndrom, ponieważ zauważyłyśmy pewną korelację między stanem pacjenta a jego wynikami badań kardiologicznych, jakim jest EKG, badanie ciśnienia i tętna. Natomiast zaczniemy sobie w ogóle od tego, czym syndrom Guillain-Barré jest. A więc jest to syndrom, w którym nasz układ immunologiczny atakuje mielinę i to będzie nam powodowało wszelkie opisane tutaj syndromy. Więc taki pacjent będzie nam zgłaszał na początku bóle mięśni, sensytyzację podczas dotyku, potem będzie to mrowienie, głównie rozpoczynające się w obrębie kończyn, później będzie ono wstępywało coraz wyżej do proksymalnych części kończyn. Zazwyczaj są to kończyny dolne. Aha, teraz wraca. Ok. I tutaj na tym slajdzie mamy opisane jak na razie takie typowe leczenie syndromu Guillain-Barré, czyli immunoglobulina, plazmafereza i oczywiście rehabilitacja, ponieważ ona podtrzyma nam sprawność pacjenta. Natomiast zaobserwowałyśmy, że takim chorym należy zająć się multidyscyplinarnie, to nie może być tylko neurolog. A dlaczego, to zaraz wyjaśnię, jak tylko przestanie mi wracać do początku. Więc tak naprawdę takim jednym pacjentem powinien zająć się cały zespół lekarzy. Tak jak tutaj mamy oczywiście neurolog, ale to też będzie kardiolog, później niestety anestezjolog, oczywiście, tak jak już mówiłam, fizjoterapeuta, no i niestety czasami zdarza się nawet, że musimy prosić o pomoc psychologa czy też psychiatry. Dlaczego w ogóle poruszamy ten temat? Temat bardzo ładnie nazwanej paralysis of the head został poruszony już w 1892 roku przez Sir Williama Osiera, który to opisał przypadek pacjenta z syndromem Guillain-Barré, który niestety zmarł właśnie z powodu opisanego paralysis of the head. I w tym momencie jakby kardiologiczny background naszego GBS-a został pierwszy raz poruszony. W związku z tym, że znajdujemy się w sesji meta-analiz i prac przeglądowych, stąd też slajd, gdzie szukałyśmy informacji. Były to 4 bazy: PubMed, Embase, UpToDate and Web of Science. Tutaj mamy wymienione nasze słowa klucze. Otrzymałyśmy około 1700 rezultatów, natomiast eliminując prace, które się duplikowały, stanęło na tym, że wybrałyśmy 13 artykułów, z czego otrzymałyśmy 131 pacjentów, a prace były z pogranicza od 1980 roku do 2020. Tutaj mamy, jakie frazy wyszukiwałyśmy, ale sobie pozwolę pominąć. No i tak jak już zaczęłam mówić, tych pacjentów z chorobami układu kardiologicznego oraz mających obecnie Guillain-Barré syndrom było faktycznie 131, natomiast problemy z arytmią miało jedynie 60 pacjentów. Te pozostałe choroby układu krążenia nie były tak znaczące dla stanu pacjenta. Tutaj te arytmie to były począwszy od asystolie, przez bradykardię, wszelkie bloki i aż do tachykardii. 16 z tych pacjentów niestety musiało przejść na wentylację, 11 zmarło oraz 7 z tych 11 z powodów kardiologicznych. Jakie były ograniczenia tych badań i w zasadzie dlaczego się zajęłyśmy tym tematem? Ponieważ okazuje się, że faktycznie duże badania przekrojowe z całych oddziałów znalazłyśmy z okresu 1980 do 1995, natomiast obecnie zauważyłyśmy trend opisywania case'ów. Te case'y są znacznie bardziej wartościowe, ponieważ mamy tutaj wiele informacji na temat tych pacjentów. Niestety te prace wcześniejsze były oparte na dokumentacji, która była niepełna. I przechodząc do rezultatów naszej pracy, dobrnęłyśmy między tymi wszystkimi pracami do konkluzji, że są badania, które powinny być stale sprawdzane, które powinny być robione u pacjenta z Guillain-Barré syndrom, ponieważ no, będzie tutaj, tak jak już wypisałam, badanie ciśnienia, tętna, będzie to EKG, no i potem poważniejsze badania. Ale dlaczego? Ponieważ zauważyłyśmy, że te zmiany w EKG, czyli to będzie, zaraz opiszemy, które dokładnie są bardzo skorelowane z szybkim pogorszeniem stanu zdrowia pacjenta. I często jeszcze sam stan nie wskazuje na to, natomiast w EKG jesteśmy w stanie już to zobaczyć. I będziemy wcześniej gotowi na to, że trzeba będzie tego pacjenta przenieść na oddział intensywnej terapii. Więc tak jak już mówiłam, results, czyli fluktuacje, wahania ciśnienia i pulsu faktycznie są zdecydowanie skorelowane z ciężkim przebiegiem syndromu. Dlatego lepiej robić EKG znacznie wcześniej, znacznie częściej, niż by się wydawało, że jest to potrzebne, ponieważ wcześniej znajdziemy problem i zajmiemy się tym pacjentem. Jakie to są zmiany? To będzie wyższy maksimum i niższe minimum PWD, niż w grupie kontrolnej oczywiście z badań to wynika. No i idąc dalej linią EKG, no to Yen negative T, który też będzie skorelowany z nadaktywnością układu sympatycznego. No i jak dalej wiemy, będzie to źle rokowało. No i zum Schluss, conclusion. Po pierwsze, pacjent z GBS powinien mieć stale mierzone ciśnienie i tętno właśnie w celu wcześniej przeze mnie wyłuszczonym. Tak samo dalej, że EKG powinno wejść do rutyny oraz last but not least, a według mnie najbardziej the most important of my speech is żeby monitorować tego pacjenta już po zakończeniu hospitalizacji z powodu GBS-a, ponieważ faktycznie znalazłyśmy sporo case'ów, natomiast okazywało się, że kończyła się cała historia z zakończeniem GBS, natomiast nie było wiadomo, co się dzieje z tym pacjentem, a bardzo możliwe, że ten stan kardiologiczny będzie ulegał progresji, a nie zostało to wcześniej wyłuszczone w badaniach. Tak samo zdarza się, że na oddziałach kardiologii faktycznie pojawiają się pacjenci, którzy mają w wywiadzie GBS. No i dziękuję bardzo. Thank you for your attention. I do pytań pozwolę sobie zaprosić koleżankę, która jest ze mną. Thank you very much.
Dziękuję bardzo za Pani prezentację. No chcemy się oczywiście dowiedzieć, żeby uzupełnić tutaj ocenę, jaki był wkład Pań w oczywiście w tą pracę. Temat no, bardzo, bardzo szeroki, no i wymagający oczywiście dużo wiedzy. Może kolega zada dodatkowe pytanie, to ja skończę na tej roli, a...
Dobrze. No to w takim razie może ja zacznę odpowiadać na Pani pytanie. Bardzo dziękujemy za to pytanie. Faktycznie mamy to szczęście, że bardzo często spotykamy się w pracy nad innymi publikacjami, natomiast ja jestem zainteresowana kardiologią, a moja koleżanka neurologią, więc tutaj się spotkałyśmy na początku w case'ie koleżanki, która w trakcie jest pracy nad Guillain-Barré syndromem w innym wymiarze, natomiast jakby łącząc nasze zainteresowania, powstała ta praca, która faktycznie jest niedoszacowanym problemem, natomiast dokładnie taka była nasza rola. Moja była bardziej kardiologiczna, a tutaj koleżanki bardziej był to strona neurologiczna. Chcesz coś dodać?
Nie, na razie nie. Jeszcze nie.
Ja tam zauważyłem taką rzecz jedną na jednym ze slajdzie, wentrikulografia lewej komory.
Tak, to powinien wracać do tego slajdu?
Ja wiem, co było na tym slajdzie, tylko dlaczego akurat to badanie?
Było to badanie właśnie nasz główny problem, jak przeglądałyśmy tę pracę, było to, że była duża dysproporcja, jeżeli chodzi o właśnie pracę z lat 80., a powiedzmy współczesne. I zauważyłyśmy tą sprawę, że w tych case'ach, które były reportowane w latach 80., znacznie więcej było badań stricte kardiologicznych. Pacjenci byli jakby we współczesnych case'ach widziałyśmy taką zależność, że pacjent z GBS-em zaczynał i kończył na neurologii, natomiast w tych badaniach z lat 80., gdzie nie było pojedynczych case'ów, ale właściwie całe badania dotyczące całych klinik z wielu lat, pojawiały się znacznie bardziej skomplikowane badania. Stąd i scintografia, stąd wentrykulografia. Tak naprawdę EKG było podstawą do całości badań z tej strony kardiologicznej.
Tak, natomiast faktycznie ja myślę, że mnie słychać. Niestety. A, dobrze, okej. Więc to też właśnie polegało na tym, że część tych badań, nawet tych już takich bardziej współczesnych, ale tych ogromnych, to bardzo często była kardiologia. Kardiologia, poszukując przyczyny zjawiska, jakby nie wiedząc tego, że to jest GBS, bo to się zaczynało na oddziale kardiologii. Więc oni poszukiwali przez te wszystkie badania, które były coraz bardziej szczegółowe, coraz bardziej nawet inwazyjne, natomiast te prostsze badania zaczynały się od neurologii. Neurologia wiedziała, że to jest GBS i ona sobie potem przechodziła do EKG i tak naprawdę tyle wystarczało. Thank you very much.
Thank you. So all the submitted papers have been presented. We congratulate all the presenting authors and participants of the systematic review and meta-analysis session. At this point, I would like to ask the president of the jury to say a few words to sum up the session.
Okay, so I want to congratulate you really a lot, and thank you for your work, for your input to the teamwork. All the topics we heard were very important, and we believe the systematic review, personally, I review that the systematic review are usually undermined and understated because, well, you work on somebody else's work, but you also can find the informations that were not looked into or were like missed. So I believe that also for your future career, this is a good practice, standing on the stage and saying a few words about the topics of your interest. So I really hope that this is one step in your career and your future, maybe scientific work. So I really want to congratulate you again. And I believe that our friend here will sum up and will tell us what we have to do next. Thank you very much and congrats again.
Thank you so much. So I would like to thank you for your words. We truly appreciate your valuable comments, accurate observations, and work on the presentation assessments. We would also like to cordially invite you for the decoration and closing ceremony of the SIMC 2023 conference, which will be held in A3 Hall on 19th May at 4:15, that is 16:15 in the evening. On the behalf of Student Scientific Society, I would like to thank you all for the participation in this session. Thank you.